So it's my pleasure to introduce today's Grand Round speaker, our very own Dr. Olcay Aksoy. Dr. Aksoy has an impressive academic background, having completed his undergraduate and medical education at Duke University, internal medicine training at Johns Hopkins University, and then his general cardiology and interventional training at Cleveland Clinic. He joined UCLA faculty in 2013 and is cherished by fellows and house staff alike. He wears multiple hats, including being an associate professor of medicine at the David Geffen School of Medicine, director of aortic valve interventions, and associate director of clinical research in interventional cardiology, and is involved in multiple trials. He specializes in structural interventions, including TAVR and MitraClip, and has really brought the TAVR program from its infancy to the successful program that it is today. When I asked Dr. Aksoy if there was anything in specific that he wanted me to highlight for his introduction, he said his biggest accomplishment has been working here with us fellows. Thank you, Dr. Aksoy, for your continued mentorship and teaching. I know I've learned a lot from you. Please welcome me and join Dr. Aksoy for his Grand Rounds today.
Okay, thank you for the kind and undeserved introduction, and thank you for having me talk today. This is actually great, so it's kind of a small world because either I was in this room or I think I was upstairs just above in 2012. I was an interventional fellow, was actually giving Grand Rounds as part of a job interview that they now fast forward, about 12 years now actually, and we're sort of 2,000 valves in at UCLA. And I think we're doing okay. So I just want to sort of go over this journey. It's kind of a long and loaded subject and a lot of slides, so I'll go through. In some ways, in some rapid fire, but we can always debate and discuss if there's any questions come up. So I have done this with Edwards in a couple of places, and then you'll actually, just speaking back to that, we do have, I just want to coin in that we do have a TAVR symposium, which is the first of its kind at UCLA really for TAVR and aortic stenosis treatment. So if you are available tomorrow morning, it starts at 7 a.m. tomorrow at Luskin, and there's breakfast from 7 to 8, and there's talks from 8 to 12, and then at 12 there's going to be lunch, and so you're welcome. There's going to be distinguished faculty from here, and actually our colleagues in Thailand are going to be giving a talk, and we have a Dr. Musa, who is also authority in the treatment of aortic stenosis as well. So we're looking forward to hopefully seeing many people tomorrow at Luskin. We had sent the email with QR codes prior to register. But going back to the topic, so what is aortic stenosis? What caused it? What are the symptoms? What is the prognosis? Are really sort of the diagnostic part. And then once we decide that we need to do something about it, what are the options? So we'll talk about medical management and some data and open heart surgery and what the data is, as well as sort of TAVR and sort of take it from its beginnings to today. And there's some literature that actually was recently published that has created quite a bit of stir in the pot, really. So we'll discuss that as well. So let's start with a patient. So this is a 75-year-old patient who came in and who has high blood pressure, lipidemia, osteopenia, comes in with diagnosis of aortic stenosis. He was told that he had moderate AS. And so he says, why is this happening to me? And one way of thinking about it, and one older way of thinking about it, which still holds true actually, and I had not done this math, but if you just say, this heart has been beating, let's assume that the heart starts beating at the time. I mean, this is at the time of birth. I don't think there's too much debate about that, but there's let's say 80 beats a minute, and we'll start sort of the clock, I guess, the day, but 80 beats a minute times 60 minutes times 24 hours times 365 days and times 75 years. So his heart has beaten, actually. This valve has opened and closed about, 3.1 billion times. So really, this valve has been around for a while, and it's done a lot of work by the time this gentleman has gotten to the age 75. So this is one thing, and this is sort of the old thought is that, okay, this is just the old, wear and tear phenomenon. Is the thing, you use up the valve and it will get old. But the question is really, from a scientific standpoint, how do we go from, the left panel, which is nice and shiny, and you can put a light through and underneath, and you'll see through the valve, thin leaflets which will open and close without too much resistance, to the panel on the right side, which you see that the thickened leaflets, along with a lot of calcifications, built up along the way. And you can imagine this puts up a lot of resistance to opening and closing, and this is when you start getting into aortic stenosis. So why does that happen? So first, a bit about the prevalence. We're talking about in some populations, if you're over the age of 65, you're talking about 7% or so aortic stenosis development. And in some literature, it's up to actually 10 to 12% as well. But this is what we had recently. And it's generally more seen in men than women. About 80% of symptomatic adults are male, essentially. And some major risk factors are present, and this sort of goes back into why the valve actually does get inflamed, and why it sort of builds up calcium and gets thickening, is that risk factors, increasing age, again, it goes back to sort of the inflammation hypothesis. Then being male, high blood pressure, history of smoking, history of having elevated Lp(a), hyperlipidemia, any inflammatory condition from Crohn's to osteocolitis, to having calcification, calcium metabolism problems like osteoporosis, osteopenia, sorts of things have been associated with the development of calcium buildup, and also aortic stenosis as well. So there's a couple of things that we have to always keep in mind. There's congenital anomalies. So you're born with bicuspid valve that you're seeing on the side on the left panel, which is seen up to about 2% of the population studies. Or you could have, maybe you had rheumatic fever growing up. We don't really see this as much, but it's been described, and we see it occasionally, rarely. And then we have the age-related sort of calcific aortic stenosis, which is, of course, the more common one that we see. So in looking back, so what causes really, and this goes back into the basic science of it, and you will see a lot of similarities with the development of coronary artery disease, which is that, okay, well, there's inflammation that could be triggered by, turbulent blood flow, or there's some malformation of the cusps, or there's some other irregularities on the cusp. And as a result, you get inflammation where you get the LDL gets stuck on the endothelium, gets internalized and turns into oxidized LDL. You get the monocytes come in, they turn into foamy macrophages, and ultimately you interact with T cells, and this turns into fibroblast activation, which will then turn into osteoblast, and which we can then turn into calcific tissue, which will secrete, the collagen and calcium, and as a result, you get thickening, and that valve that you saw earlier, which is the thickened leaflets, has a lot of calcific nodules. And this can, of course, progress over time, depending on the degree of inflammation, depending on the underlying risk factors, and of course, over time as well. So what is our answer to the patient? Why is this happening to me? So you can say advanced age, hypertension, hyperlipidemia, osteopenia, or you can say all of the above, which is, of course, the case, because this sort of medicine is never really that simple, right? So there's a lot of risk factors and a lot of factors at play if a patient ends up with a significant degree of any kind of disease, really. So our patient then has more questions. He says that, well, yeah, I found out my aortic valve area is 1.2 centimeters squares. My mean gradient across this valve is 25. And what does this mean? Do I need to take medicines? What can I do? What do I do about this valve? So a couple of things to know, and this goes back to 1960s, initial Braunwald papers, where they looked at the survival for patients who had severe aortic stenosis without any treatment, because they did not really have any options. And this was sort of, at the time, that was published in patients who had age of 60s. This was sort of modernized, I guess, adopted in the 80s, which is what you're seeing here, essentially, is that once survival, you gradually, this curve is going to always go towards zero, but especially if you start having symptoms with aortic stenosis, you notice a significant drop-off very quickly in patients who have symptomatic severe aortic stenosis. And really the worst thing to have is symptoms of heart failure, and that's shortness of breath and, leg swelling, etc. And then and you really, at the end of 2 years, most everybody's gone, unfortunately. And then you have syncope, then that's 4 years, and you have anginal symptoms, that's about 5 years is what you're getting into. So not a good thing to have, obviously. And approximately 50% of the untreated patients with severe AS will die within 2 years of experiencing symptoms. So this is something to take really good care of, really get on top of very quickly. So why do we have symptoms? I think this is important to know as well. And this really has to do with the sort of the pressure overload of the ventricle. And if you imagine is on this panel, you're seeing the normal. What opens the aortic valve is really when the pressure in the left ventricle is increased beyond that of the aortic pressure. And if you remember the pressure volume loops, LV will squeeze during systole, and then the valve doesn't open immediately. It will generate the pressure first, and then when the pressure in the LV goes that up on top of the aortic pressure, and the valve will open. It's a very passive sort of a phenomenon. And usually if the pressure really crosses zero, the valve should open immediately. Now, the caveat to that is when you do have valve thickening and aortic stenosis, and in this case, it's kind of an extreme thing, but the aortic pressure here is 110, and to be able to open, let's say in this particular case, in somebody who has a gradient of, let's say, 90 in this particular case, your left ventricle, I mean, give or take, has to generate a pressure of about 200. So imagine that every single heartbeat that we talked about, heartbeat being, let's say, 80 times a minute, 60 times 60 minutes, etc. Your heart is lifting heavy, doing a lot of heavy lifting with every single heartbeat. So eventually this valve will have problems. This valve will cause problems on the ventricle. So because you're dealing with constant hypertension of the left ventricle, you're going to get anginal symptoms because you're really overworking your muscles and your coronaries and asking for more ingredients to work properly. Like you got to generate ATP to squeeze and generate these numbers. You need more sugars, you need more, blood flow. And so that puts stress on the coronaries, and then you get chest pains. Then you can have heart failure symptoms. Of course, to be able to generate the pressure of 200 with every single heartbeat, then you need to have higher filling pressures, and the higher filling pressures will then translate back into your left atrium. And left atrium will go back into the lungs, and your wedge will be high. In between, you will get pulmonary edema. You can get leg swelling. Your cardiac output will eventually drop, and then you can, go into sort of lack of energy. I don't feel right. Perfusion problems, creatinine starts rising, etc. So heart failure symptoms. And last thing is, let's say on a day that it's hot outside and you're gardening and you eat and drink that much, maybe you're not able to generate that 200 pressure. So maybe that particular day, the most your heart can do on a dehydrated condition is, let's say 160. Well, you're going to lose 90 of that across the valve. So then you have a systemic pressure in the aorta of 70. Because you gotta lose that pressure of 90 across the valve. So then now you're dizzy. So some people, have syncopal symptoms. Of course, arrhythmias and things come along, but we usually think about these three cardinal symptoms. And that's when we start saying, okay, the patient has symptomatic aortic stenosis. But this is sort of the mechanism and thought process of the overload of the left ventricle. So what can we do about it? Again, going back to the patient's question, is it preventable? Have people tried? Of course, people have tried. And honestly, if anybody's interested in this type of research, this is sort of my dream of trying to do this sort of work. But, if you're interested, let me know. I think we're going to get into some funding soon. And hopefully we can look into this more detail. But people have been looking, and people have tried different types of medicines. And of course, the first thing, because of its similarity of development of the pathology to coronary artery disease, people have looked at statins. Small studies have looked at ACE inhibitors. I sort of was interested in bisphosphonates back in the day. So what does the studies show? So what have the studies shown so far? Well, there was initial excitement actually in 2005 where they looked at rosuvastatin affecting aortic valve endothelium in the study called RAVE study. And then when they looked at it, they saw that the p-value was significant in slowing down the progression of aortic stenosis. So these are treated patients versus untreated. And what they found is that at the follow-up time of 78 weeks, the treated patient, rosuvastatin treated patients progressed their aortic valve and getting more severe, more slowly. As a result, there was this excitement, well, maybe, we can put people on statins and we can actually sort of slow down the progression of aortic stenosis. Now, this was, of course, followed by atorvastatin study with the SALTIRE study, which unfortunately looked at the same things, so aortic valve calcium score and aortic velocity, sort of different endpoints, but ultimately valve area, it didn't really show any benefit. So another study, then they looked at rosuvastatin one more time, astronomer study. They looked at aortic valve area, and really no difference there either. And then finally, the CEASE trial came out, and then that looked at more of the same. They looked at the change in aortic jet velocity and really did not show any difference. And this is so brand name Vytorin, but really simvastatin plus ezetimibe, you're hitting the sort of cholesterol pathway along with the inflammatory pathway. and really no difference, no benefit. So really kind of disappointing that this didn't work, although some people will argue that, well, we only took patients who had significant moderate aortic stenosis. If you look at all comers in these studies, then maybe we should have started statins early, etc. But that's just sort of a hypothesis that's not been followed up at this point. ACE inhibitors, small case studies were looked at, and it didn't really show any. It showed some suggested benefits, but bigger studies didn't really show anything. And bisphosphonates, again, this is sort of something I was really excited in. I thought calcification pathway is something that may be helpful, but we looked at patients, actually 438 patients, they didn't really show any benefit. And then we looked at again back in the day about 200 patients. This is a retrospective study again. 4.5-year follow-up. We looked at patients on basically on ACE inhibitors and ARBs, and didn't really show any improvement in slowing down the progression of aortic stenosis. And then one thing that actually was interesting is that this was an idea from a surgeon actually, and he said, I've noticed that when I put in bioprosthetic valves, if they're in calcium or vitamin D supplements, I've noticed that their valve gets bad sooner than later compared to people who don't take supplements. So we actually did look at our surgical database and looked at aortic valve replacement patients. In that database, it came out that if you take calcium or vitamin D or combo supplements, this is a retrospective study, that your valve actually does get worse sooner. As a matter of fact, they need to get replacement sooner than people who don't take supplements. This was a predictor of aortic valve failure of the bioprosthetic aortic valve. So that's kind of interesting. And then this was sort of followed up a couple of years after I left a fellowship with a native valve. And so there's some literature accumulating that, and even in native valves, taking vitamin D and calcium supplements may not be a good thing for you. So this is what the study looked at, where patients over the age of 60 with mild, moderate aortic stenosis were looked at. And they followed for 2 years. And then when they looked at sort of aortic valve areas and gradients, they showed that there was a trend there was a significant actually findings towards that the valve are going to calcify and get worse more quickly. So this vitamin D calcium, I think, is an important subject and something to be followed up on. And, with the number of supplements a lot of people take these days, I think this is not to be taken lightly. So occasionally I tell people, when we discuss this with patients, I tell people, look, you have reason to take calcium D, vitamin D supplements. That's one thing. But if you're taking it because your kind of neighbor is taking it or Google says you should take it, then it's probably not a good idea. And unfortunately, most people take it because really everybody else is taking it, not because necessarily they need it, for any particular reason. The literature on the osteoporosis and vitamin D and calcium supplements, etc. Actually, there's several papers on that too. That's to be discussed, I guess. That's a different topic, but it's interesting topic. So what is the medical sort of guidelines in terms of approaching these patients who have aortic stenosis? Really, there's nothing in the literature that says, okay, do this or do that, other than, there's nothing about reducing the progression of aortic stenosis. It says treat the blood pressure, treat if a patient has hyperlipidemia, coronary disease, treat that properly, do a good job at those things. But really, there's nothing that says that there's any benefit to any medications really in the literature. So that's sort of the medical side of things. But now let's sort of focus on okay, what's next? How do we get to the bottom of this diagnosis? And then what do we actually do about it if the patient has severe symptomatic aortic stenosis? So, of course, there's a lot of ways of looking at the valve. I mean, you can listen to the murmur. You can do, chest X-ray will show some calcium. EKG can show LVH and strain, those sorts of things. You could do a cardiac cath, which remains the gold standard to measure pressures, really. But then, echo is more than 90 plus 99% of the time, it's going to be an echocardiogram. And what are the criteria? So the jet velocity for severe is more than 4 meters per second, the mean gradient more than 40, valve area less than 1, and valve area index, again, if somebody who's of larger stature may have a valve area 1.2, but then if they're really a big person, if you normalize that with the body surface area, maybe they actually do fall under having a severe aortic stenosis case. And so that cutoff for valve area index is less than 0.6, actually. So these are numbers to generally keep in mind. This is what you're going to see on, if on some of these tests it comes up, but these are the numbers to keep in mind. Okay. So the patient, again, had said 1.2 valve area and gradient. I think it was at 25 or so. What are we going to tell him? Well, we can't tell him he needs medicines to stop disease process because we don't have any data for that. He does not need surgery. He's not symptomatic, and we don't say no treatment options in general, but he needs close follow-up with us. We generally, do follow-up echocardiograms every 1 to 2 years, depending on the numbers, and sort of see how the patients do. And just to keep in mind, this is something that I think everybody should sort of keep in the back of their minds, is that what I tell patients, like this patient, for instance, has a valve area 1.2, and he says, well, when am I going to need something done? Like, this is actually an important question. So in general, if you look at the statistics of this, on average, people will narrow their valve 0.1 centimeters squared per year if the disease process has started, and the mean gradient will increase by 7 to 8. So if somebody says valve area 1.2, mean gradient 25, so, they probably have about 2-3 years left on the valve. You never know. If they have, end-stage renal disease, they may progress faster. If they have a severe inflammatory condition, they may progress faster. But this is sort of generic, fallback to answer, is that 0.1 area and 7-8 millimeters of mercury per year.
Okay,
All right.
so,
Yeah.
Does aggressive blood pressure management makes a difference in terms of progression?
No, there's no data that blood pressure management makes a difference. There's no data that cholesterol managed statins make a difference. We just don't have data. Really nothing. So honestly, I think there's a bunch, probably several Nobel Prizes pending in this whole calcification area. Like, if anybody wanted to get into research, I mean, this is a massive, massive area of research. You will make people probably live several years longer. It's sort of like the treatment of coronary artery disease. If we can get to the bottom of calcium buildup on the valves and the coronaries, I think that's going to add several years to patients' lives, and really a major area of research, I think, to go after. But no, we do not have any medicines to say that you fix blood pressure, because the disease process is inflammatory. So if you lower blood pressure, okay, you're not forcing the heart to work as hard, because your systemic pressure is 110, let's say, and then your heart has to generate a pressure of 40, the valve gradient is 40, so your heart has to generate a pressure of 150 to be able to fight that. Now, if your systemic pressure was 150, now your heart has to do 190, so you may get more symptoms more quickly, sort of thing, but it doesn't do anything to the valve, at least that's anything proven, Now, you could say, in theory, if you have high blood pressure, then you're having more stress on the valve because you have more turbulent blood flow, because the high blood pressure, as I said, maybe that will make it progress more, and then maybe you control the blood pressure, maybe the inflammation levels on the valve, valve is not torn up as much, over time. You could say that, but that's sort of in theory. There's no actual data that actually slows the progression of the valve. So it'd be a good study, though, but that's what we have. So sobering perspective, I mean, this is a slide that's now many years old. It's like 10 plus years old, I think. But this is severe inoperable AS. If you don't fix the valve, it's worse than a lot of cancers. So if somebody has lung cancer and they're worried about that, and they have severe symptomatic AS and they're not worried about that, it's probably not the right thing. Not that lung cancer is that much better, but this is a bad problem to have. So typically, this is Eric Yang. Every time we talk to Eric, we say, if somebody has some oncologic problem, even if stage 4 cancer, sometimes, we talk to the oncologist and we talk to Eric, and, like, we don't fix the valve. This patient has maybe months left, as opposed to the cancer may have treatment options. And so we try to still fix the valve, even if somebody has, progressed cancer, because, with these current therapies, one, they'll probably live a longer time than what we were used to. Number two, we a lot of times actually do the fix the valve so that patient can get therapy, because a lot of these therapeutic agents can put undue stress on the heart as well, not just cardiomyopathy, but also fluid buildup, heart failure signs and symptoms as well, just because they have to get a bunch of fluids and stuff with the chemotherapy as well. So this is something to note. That's not a good thing to have. But what are the options? Again, so the only option used to be open heart surgery, and it really works. And if you look at the patients, actually, there's a study that looked at symptomatic and asymptomatic patients, and you actually see that, even if you don't have symptoms, there's some actual data in long-term follow-up that fixing the valve earlier on may be a beneficial thing. And I bring up the asymptomatic part. This is now an old sort of meta-analysis, but there was a paper that came out of Korea a couple of years, like 2 years ago, or 3 years ago, actually. And for asymptomatic severe AS patients who have jet velocity across the valve 5 meters per second or more, and that actually did show mortality benefit as well. So there's currently studies ongoing, which is going to be published, actually come out soon, the Unload trial that looked at moderate AS with low EF. And there's an early TAVR study that's looking at asymptomatic severe AS. So there's different sorts of indications. We don't truly know where the sort of clock starts with the mortality risk going up exactly. Although we say, symptomatic, the problem is a lot of the patients are, older, and then they say, oh, I don't have symptoms. Although, well, maybe you don't have symptoms because you're not doing as much because of orthopedic problem, etc. So it's sort of unclear in a lot of ways, but so we're trying to find that right time frame to when we should get aggressive with treating these patients, really. But really, the valve, when it's not addressed, it's a problem, and it does kill people, unfortunately. So how is surgery done? Again, the left side is mechanical, the right side is a bioprosthetic valve. This is one of my patients who I saw actually when I was pretty junior. I think this is like, maybe I saw him 9-10 years ago now. He was bicuspid. He was about 70 years old, and he couldn't breathe, and he wouldn't go to the doctor because he was worried he didn't have good insurance. And he didn't, but then he showed up in the office short of breath. So then we sent him to the emergency room right away because EF was like 25-30%. He had a bicuspid severe AS. And at the time that, the trial, he couldn't enroll in any trials because bicuspid sort of thing. And at 25-30% EF, he ended up getting surgery. So surgeon cut the valve out and sutured down this nice new valve, which I'm still seeing him actually. He's actually doing great. His EF completely recovered after surgery, and he's been playing tennis. And now he's 80 plus, and he's complaining that he's sort of getting tired when he's playing tennis. So he's still doing very well, and the valve is functioning normally. So this surgery can be great for many patients still. The problem is, a lot of patients don't get surgery, and depending on where you look at the literature, 40, 50, 60% of the patients, depending on the paper, will get sent home because they're not good candidates for surgical treatment. And this is really sad for me to say. In residency and in fellowship, we had sent a lot of these patients home because we said, look, you're going to die on the table, and we can't really do too much. We would do a balloon aortic valvoplasty and then give them some Lasix and say, just we'll do what we can. But they didn't have any options. And so really, this has been sort of a problem. So people have tried different things. And this balloon aortic valvoplasty was tried, people started trying this in the 1980s. And the problem is that you're not really replacing the leaflets. So you're sort of pushing the leaflets out of the way, and then they sort of recoil back again. And sort of limited by restenosis, the valve will go back to what it was, 80% restenosis rates at 1 year. And really never had any data for improved survival. So this guy, which is interesting, actually, I think Rushi actually is trying to bring this patient as part of the biodesign program to give us grand rounds. So this guy said, okay, do you guys know when the first stents were done? So first ballooning, actually leg ballooning was done early 70s. The coronary balloons were done in 78. And the first coronary stents came about in 1988. So this guy in Germany, Denmark actually, he says, look, we were stenting the coronaries, why don't we stent the valves? So he actually goes home and he sort of gets a couple of wires together and sutures down this cow tissue onto the wire and gets a pig model and implants it into a pig. And then he actually publishes this and comes to the US. This is him actually back then. I met this guy actually, when he was giving grand rounds, and he said, I sat there all day in front of my poster that nobody came, and basically 2 people came. They said he's an idiot, just go back to Europe. What are you doing in the US? So this is basically how it all started. And then after that, this 1989 is what he just started working on. And after a while working with a number of surgeons, and actually a company bought out this idea, which is Edwards back in the day, and they got the patents from him, etc. And then ultimately designed this sort of final version of this valve back in that day. In 2002, they put it into a 57-year-old guy who had actually bicuspid valve, and they put it from the atrial septum into the LV and integrate through the LV into the aorta. And then EF 10%. They put the valve in and it actually worked. And this guy lived 4 more weeks, except that he was septic, so he died from sepsis. But then, valve was functioning and his heart was recovering actually in the process. So this is sort of proof of concept in humans. And that's sort of what opened the door for, what's next, which is this. We actually now have 4 valves approved in the United States. There's several more valves the rest of the world, but FDA approval has been granted to these 4 valves. Now, we don't really have Lotus Edge. They took it off the market because they couldn't sell. Boston couldn't sell this valve. They have this other valve that they're working with and trying to get approval for that one. But really, we have the Sapien 3, which is a cobalt chromium stent, which is what coronary stents are made out of, cow tissue inside. Then we have this Evolut FX by Medtronic, which is a nitinol frame, which is sort of self-expanding sort of shape memory device, inside of which there's pig tissue. And then you have the Navitor here, which is also a nitinol frame, but it's intraannular. So this is supraannular Evolut, and then the others are intraannular valves, which come with their own ups and downs, really anatomically. So how is the TAVR done? This is something you've seen before and we've looked at, but basically the valve, is going to end up in the native position, but this is the BAV portion of it. So the wire is into the ventricle. You sort of inflate this balloon. If you do, to make some room, we used to do this as routine practice for every single case back, up to maybe 6-7 years ago, to make room for the valve. But we learned over time that the more you manipulate the valve, the stroke rate's a little bit higher. So then, if we don't have to, it's not heavily calcified. If we think that we can push the valve through into the right place without fighting the valve too much, then we don't have to balloon it really. So we really don't balloon the valves as much anymore. So this is a Sapien device that's sort of balloon mounted. So it's the intraannular device. So we assemble it in descending aorta. We go around this wire. So you're sort of going around the arch. So we try to really manipulate that wire so that we don't scrape the arch. But that could be one source of strokes, obviously. And then you sort of come down and negotiate, and you can sort of see that the coronary ostia are nearby here. And then we try to place this in the right place. You go too low, you may embolize, or you can hit the conduction system. And so pacer rates are higher. If you go too high, you can maybe get in front of the coronaries quite a bit. So you can cause other problems, or you can embolize the other way into the aorta. So the placement is sort of a big deal, as you can imagine. And then you inflate the balloon with rapid pacing, and then valve is in place. And after a lot of preparation, the whole process, we're down to sort of skin to skin is about now 40 minutes or so, and half hour in the front end for anesthesia, half hour on the back end for anesthesia. And really the whole procedure for the patient is less than 2 hours. But for us, really working is about 40-45 minutes. And then the main part is inflation of the valve, really is about 5 seconds. So it's really, you have a one shot at this, but it really works pretty well, actually. And this is what you get at the end of it, really. So it's a nice open valve. So what is the data? How did it start? So we said 2002 was the first human patient. This got published in 2010, which was the PARTNER 1B study. So they looked at that particular valve. Initially, they said, well, we can't just start doing this in low-risk patients. Let's start with inoperable patients who are going to die and they have no other choices. And that, unfortunately, I happened to be one of the fellows who were randomizing these patients, giving the news to these patients that were randomized to medical therapy, or TAVR back in the day. And it was really sort of, unfortunately, a very dramatic situation back then. But what they found, as expected, is that if you do stent therapy, which actually includes the real LASIX and a lot of BAV, actually 70+% of these patients were getting BAVs and serial BAVs as well, balloon valvuloplasties. But even then, you have about 25% absolute reduction in mortality at 2-year marks with this PARTNER 1B study. This is this is a balloon expandable valve. So that actually got the valve approved, for the high risk and inoperable cohort, which is what this was. PARTNER 1A then compared operable patients, but high-risk patients, the high-risk defined by STS score more than 8%. That is 30-day mortality with surgery at 8% or more. That would be high risk. And they compare surgery and TAVR, and what they found basically is sort of overlap, for the most part, overlapping curves. And mortality is still pretty bad. Again, keep in mind, these are 85, 90-year-old patients with several comorbid conditions who are high risk. Anyway, so their mortality, no matter what, is high. Even if they didn't have any aortic stenosis. But, at least in this case, what they showed was TAVR and surgery is equal. So why don't we not put the patient through open heart surgery? So that was published in 2011. So that ultimately led to the approval of the valve in 2011, again, by the FDA. So that's when these programs got started. That's when I came to interview at UCLA in 2012, which is sort of, I guess, for me, it was sort of a lucky time to be graduating from fellowship. So here we are now, talking about this stuff. So primary endpoint, this is the other self-expanding valve, which is the Medtronic valve, which is the Evolute. Core valve was the original name that sort of evolved into Evolute. And now it's on to the 4th generation. But they did a similar study. These are high-risk patients. They looked at 1-year all-cause mortality, and they showed, in this case, superiority in terms of mortality to surgery, actually, with their valve at the time. This valve was smaller in profile, the sheath that we use, etc. They did show some benefit, actually, over and beyond the SAPIEN valve back in the day. And then, so that's high-risk cohort, inoperable cohort. So what about the low-risk cohorts? Because all these TAVR programs started popping up in 2011. But what the question is, everybody wants them now. So now we have patients coming in. They're like, 55, 60-year-old patient. I don't want to open heart surgery, put a TAVR valve in me now. Well, it's not approved, so you can't really do that. But then you can do studies to see if that's actually going to work. So this is the PARTNER 2 study. In this study, they looked at patients who had moderate risk, and that's defined by having STS scores of 4 to 8% ballpark. And they randomized 2,000 patients, and they looked at several things. But really, the main thing is the transfemoral cohort, which is what we do for the most part. But they also had transapical and aortic cohorts, transaortic cohorts, which is a small part of this. But what they looked at is death or stroke, and this is as treated patient population and surgery and TAVR. Numerically, TAVR looked a little bit better, but then, in the moderate risk cohort, but the p-value is not significant. So really similar sort of findings for the moderate risk territory as well. And then if you look at the transfemoral cohort only, if you don't include that transaortic and transapical cohort, the p-value was significant in this case, 20% versus 16%, 16.3% death or disabling stroke. So this was really encouraging that, well, maybe TAVR is actually better than TAVR, because this is now the 2nd generation valve, SAPIEN XT, the 2nd generation. So maybe the new generations are better, and these are low-risk patients, so they actually do better with TAVR as well. Now this is a SAPIEN 3, so in parallel to the PARTNER 2 study, they came out with the SAPIEN 3 valve, which is 3rd generation valve. They looked at the outcomes with that, and they found actually even lower mortality with that, which all-cause was 1.6% at 30 days and 1% cardiovascular mortality. And they looked at stroke, and then 1.4% all strokes, and disabling strokes were 0.8%. So what they did is this side registry of S3 cohort, they then compared that with the moderate risk, because the same sort of study, it's just the S3 came halfway through this trial. So they took the surgical cohort and then compared that with the S3, and what they found is mortality was 4% at 30 days with surgery and 1.1% with TAVR. And then you see the 13 versus 7.4% at 12 months, better for TAVR. And also disabling stroke was 4-fold higher with the surgical cohort as well. So now you have mortality and stroke benefits from doing TAVR in this moderate risk category of patients with the newer generation valve. So this ultimately led to the approval in 2016 of the TAVR for moderate risk cohort patients. So that's okay, that's check. Okay, that's great. But then you still have the low risk patients, because 4 to 8% is still sort of significant risk. You still have lung disease, you have kidney disease, etc., to get to an STS of 4 or more. So then we still have patients coming in. They're like, well, I don't want surgery, so what am I going to do? It's low risk. So they would go from hospital to hospital to convince somebody to really do these procedures. So so then low risk trial came in, because we didn't have the answer to this. So they looked at the STS cohort patients with low risk that are defined again by STS less than 4%. And they only looked at transfemoral, and they compared randomized control in a randomized control fashion of surgery versus TF TAVR, looked at death and strokes and rehospitalization. And they looked at a couple other registries, which is bicuspids, alternative access, valves, etc. So this is the results that was published several years ago. And again, this is a truly sort of low-risk cohort. Again, though, low-risk cohort, age is 73. You have STS score 1.9, okay, low risk, and then nobody's frail, because you could be 70 and frail, right? It's a history of strokes and etc. But everybody's fairly actually good 70-year-olds essentially end up getting randomized in this trial. And this is the 1-year data, which is that death, stroke, and rehospitalization, surgery looks worse. But then you can argue rehospitalization is not kind of like one of those, it's one of those things that the company used to sort of make their valve look better. So if you look at the death from all cause, TAVR is 1% death at 1 year and surgery is 2.5%. And then stroke is sort of similar in favor of TAVR, 1.2 versus 3.1% in favor of TAVR again. So again, looks good for surgery as well. And this is, again, the low-risk patients. Here are some more raw data that to go over. And then, of course, the other company. So the Edwards is making the SAPIEN. That's sort of running with it. They're the first to market. And there's a second company is Medtronic. They're doing their own trials. Again, Abbott has this other valve. Boston has this other valve. Everybody's sort of rushing to, get data because this is a big market. And they, companies want to make money. So they're trialing these things. And the self-expanding valve, they looked at their own low-risk cohort, very similar patient population, 73, 74 years of age, STS score 1.9, nobody's frail. In this case, when they looked at death and disabling stroke, which I think is a more fair comparison, TAVR again looked better. And then now if you look at the data for death, 0.8% death at 30 days and surgery 2.6. That is also 2.9 versus 4.6 in favor of TAVR. You can look at strokes. Strokes were similar in this particular case. And then, there's these two trials basically for the low risk indication led to approval in 2019 for essentially the valves to be done in low risk population as well. So now we're getting to you guys getting into residency and fellowship. So this is real. So you guys were probably when you were in your residency training, you were reviewing some of these papers because
high school.
some wasn't. Yeah, you may have been in high school. I don't know. You're like.
I was a third-year fellow when Partner came out, so I saw it at ACC, and I saw that I was like, I got to be a part of this.
Yeah,
When I
good.
get to represent Partner 1.
Yeah, it was.
So,
This is like history in the making.
no, you guys have no idea. Just I mean, it's like mundane for you guys, but literally, it was like one of those mind-blowing trials when they presented it at ACC Chicago, I think in 2011, and like it got a standing ovation. Like it was also a Cleveland Clinic propaganda video. They spent the first 15 minutes just talking about how awesome Cleveland Clinic was, but like, and the video was hilarious. I'll tell you about it.
All right, let's focus. Eric is in the house, so we need to focus again.
Yeah.
So 5-year outcomes. This is a warning sign because I actually have a little bit of a discomfort. I will say, as a person who does TAVR, it doesn't make me feel right that we're leaving all this old valve aside and we're pushing it to the side. And there's this valve swirl, the blood is swirling around. This is neosinus that we're sort of creating, and there's problems down. It sort of tells me there's going to be some problems down the line. We just don't have long-term data, and that's sort of what everybody felt. So everybody says, we really don't have truly long-term data, but that is coming now slowly. And we're not, 20 years out, but we have several years data. And this is something that gave me a little bit of a warning sign. Now, the good news is that you look at the aortic valve area, pretty consistent and stable. You look at the aortic valve area, aortic valve gradients, consistent. Now, one issue that the initial generation valves had to deal with is this if you have significant paravalvular leak, that's a problem. You have higher mortality if that's the case. The discussion had always been, okay, well, you have more leaky valves paravalvularly because you have more calcium buildup, and that is a sign of more end-stage renal disease, etc. So those have all been criticized, but newer generation valves, they added these outer skirts, and we have better ways of sort of sizing up these valves. Initially when the original partner studies were done, they were deciding on the size of the valve based on the LVOT diameter. And we all know the LVOT diameter is not really exact indicator of what the valve size is really. So CT is standard of therapy now to diagnose, decide on valve sizing. Of course, we need Eric's expertise in some cases where we cannot give contrast, etc. But PVL rates have been significantly reduced. But this is, at the end, a 5-year data is reassuring that for the most part that aortic valve area and gradient stay the same. But this is something that's interesting. At 5 years, the TAVR curve looks better. I always kept pounding on the fact that, TAVR looks great at 1 year, 2 years. Well, if you look at 3 years, death and disabling stroke curves start crossing over, and then surgery looks a touch better. So I don't know how this is going to look in several more years. But this is something to think about. This is based on the partner study. And then, this translates into the guidelines, the data. So keep that in mind for long-term follow-up. But what do the guidelines show? And again, I want to coin in. Eric is going to talk more about this tomorrow. little more detail, but you know, the literature will say if you have severe AS with high gradients, patient have symptoms, 1A, you got to get the valve done. If asymptomatic, you have low EF, again, 1B this time, that with non-randomized studies, you got to get the valve done. If you have somebody asymptomatic, but their velocity is more than 5, it's 2A. This is based on that Korean study that came out a couple of years ago. If you have somebody who is asymptomatic, they're low risk, but their BNP is going up. Now, this is sort of a window into, I don't have symptoms, I feel okay, you know, but then your BNP is 3 times normal. That's a sign probably that, okay, like maybe you're just not doing enough, sort of thing. Is a window into sort of one of those patients who have orthopedic problems, just valve is bad, they just don't feel it, you know.
I'll talk about this too, but maybe you can talk about, I'll get your thoughts on this, but those 2A indications are actually for surgical SAVR, at least in the guidelines.
Correct.
The algorithm, not
Correct.
TAVR.
Right.
You know, people who are low surgical risk, it is reasonable to refer them for SAVR with those hemodynamic or biomarkers. So it's important not to have indication creep if you're really going by the data.
Yep. Yep.
You know, what we do about someone who has those things and is a poor surgical candidate, I don't, you know, they're probably still higher risk, but you know, it's not necessarily evidence driven to do that. You know,
Yep.
you have to just be, you just have to go with what's best, you know, what data you have and what's best for the patient. So.
And this goes back into the last one. EF is gradually dropping, so it may be a sign that the heart, you know, is starting to get in trouble here. So don't wait too long. It's the last class 2B if the EF drop on 3 consecutive echocardiograms. So then, okay, well, you have decided you're going to operate on the patient. This is surgical again. We're still in the surgical space. So if the patient is less than 50 years of age, maybe think mechanical or a bioprosthetic. So 50 is sort of where these guidelines is drawing the line. If you're over 65, you should more think bioprosthesis or a mechanical valve. So that's sort of, then we're left with this area where it's 50 to 65, it's unclear. Now, really, it's unknown, really. It sort of depends on patient lifestyle, etc. But in truth, because of the TAVR, 50 and over, you can say bioprosthetic probably. And we always say, okay, well, you get a bioprosthetic now, and then we can do a TAVR later, and maybe another TAVR. And when you're 70 something, we'll do TAVR. It's just this lifetime management has become a big sort of to do and something that we think about all the time, every time we see a patient like this. And these informs the guidelines. So then a little bit more detail. So then when to do SAVR versus, you know, TAVR, basically, if you're younger than 65 and you have more than 20 years to live, which who knows how to predict that, but if you have no real comorbid conditions, you're like younger than 65, or you're 70 and you're running marathons, you may be around for a while. Maybe surgery is a good thing for you, first line therapy. But if you're 80 or over, or you have less than 10 years to live, then probably you should think more TAVR. Anyway, these are sort of more obvious things. Another thing is for symptomatic patients, and if they're high prohibitive risk surgically, TAVI, if you have more than 12 months of survival, then TAVI also makes sense. But if you don't think patient is going to live more than 12 months, probably should not put them through a major procedure. We always say, oh, TAVR is okay. It's not a very risky procedure to do, but there's still some association with, you know, death or stroke, you know, pacemaker in the last year of their lives is probably not fair for the patient either. So it's something to think about. Now, what happens if you don't follow but those are the guidelines. So what happens if you don't follow the guidelines? And if in our great state of California, which Eric is going to probably talk about this tomorrow anyway, but so it turns out that they surveyed patients who are younger than 60. This is California Medicare data, or yeah, this is California data. I don't know if it's Medicare. This is administrative database. What they did is they looked at all patients who are younger than 60, and they did a propensity matching of 358 pairs of patients. What they found is about 46% of the patients get TAVR anyway. You're younger than 60. So we're not really good at following guidelines. And so this sort of goes in. We really have refused many patients, but in the end of the day, occasionally you hear back that, oh, you know, they went some other hospital and got their valve anyway, TAVR anyway. So this sort of stuff, indication creep that Eric is talking about, does happen. But okay, I mean, that's one thing, you know, but what does it even mean? So I show these patients, unfortunately, this didn't come out well. I show the patients this graph. I actually open up this paper and then show them this graph. It's like, okay, you're 55, you don't want surgery. I get that, nobody wants surgery, but look at this. And then you show them that you're actually giving up on several years of your life, potentially, by going for TAVR first. Because this is what they showed. So this is something to keep in mind. So we can't just go around and say, oh yeah, just let's TAVR everybody and, it'll all be okay. But it won't be okay. The younger patients will probably get some harm
Yeah, you
from
kind of
doing
wonder
TAVR
if maybe
first.
this was, you can make the argument against propensity score matching, so there's some unmeasured confounders.
Right.
but maybe it's the
Statistics
high-risk
aside.
young cohort, but I really doubt that many people in California who are younger need TAVR. I don't think also look at bicuspids as well, because that's pretty young to have people less than 60 get AS.
Correct. This may be more related to bicuspids.
Yeah,
True.
in other words, which TAVR is not indicated on label for too, so,
Yep.
you know.
All right, so now we have the patient. A couple of years has passed. He's 79 years, and his echo shows valve area 0.942. What are you going to do? So you got to refer them to the heart team. In truth, yes, this is a patient who clearly looks like it's probably the first thing that comes to mind is TAVR, but we don't truly know until we talk to the patient, get the history. You get a CAT scan. I don't know those coronary. We haven't even gotten into this TAVR nuts and bolts talk, which is another talk to give, but coronary may be too low. There may be annular calcium. Their annulus may be too large. We have a patient downstairs shocked that we want to TAVR, but his annulus has a 30% defect in the annulus, and the valve measures 950 millimeters square, which is the largest FDA approved indication is 696. So the valve is going to embolize. So I don't truly know. So when you guys see patients in clinic, say, oh yeah, we're just going to get a TAVR for you, may not be the right thing to say to the patient. I would say that we're going to have you get seen by the specialist for the valve, and we'll decide what's best for you. And my party line for a lot of these patients who, unfortunately, we see, fortunately or unfortunately, you got to do the right thing for the patient. Patient is 75 years old. They want TAVR. I want them to have TAVR. But sometimes the easier thing, which is TAVR, is not the right thing for that patient. And it all sort of depends on anatomic factors and a lot of other things. So we like to get all the data first and then make a decision as a heart team and sit down and decide on these things. So that's sort of that part of the discussion. But then what about the longer term data? Now, it turns out Europe will always have longer term data than the US because they're a lot more relaxed in getting CE marks and such, which CE mark in Europe, basically, if FDA approval of Europe, you show that you're not harming the patient and you're easier to get a CE mark. And FDA, you need to show benefit of a device over top of the current therapy to get approval or equivalency to the benefiting device. In Europe, it's a lot easier to get, CE mark. So TAVR valves have been around in Europe for longer than the United States. And so they have longer term data. So this is just this Nordic aortic valve intervention NOTION trial. They looked at self-expanding valve, it's a core valve basically. And they had randomized 145 patients to 135 patients on the TAVR side. They looked at all-cause mortality, stroke, and MI. This is 10-year data. Curves are overlapping up top. Furthermore, they looked at structural valve degeneration and biostatic valve failure, which would be repeat surgery. And they actually showed that TAVR may be more durable, which is the contrary to the general concept that, oh, well, we don't have long-term data. These are valves that are sort of stented. It's sort of weird design anatomy. Maybe it doesn't work well. Well, maybe it does, and then maybe they actually last longer. It's sort of unclear still, but the data is accumulating. But the data does look favorable on the TAVR side for this self-expanding valve. What about the US side of things? And 4 or 5 year follow-up data on the low risk cohort is basically, this is the 5-year data. This came out actually about a year ago on TCT and published. And they looked at death from any cause. You're seeing that again, curves are sort of crossing a 3-year mark. TAVR is sort of on the top end of this thing and looking a little bit worse, but then p-value is nowhere near significant. So we need longer term data. Stroke side of things are matching up at about 5 years. TAVR does look more favorable in low risk cohort. And of course, surgical patients will always have more rehospitalizations. So in general, more to follow. This is the Edwards side of things. This is the Sapien side of things. But what about durability of the valve once it's in? It's generally pretty good. If you look at the aortic valve gradients or aortic valve areas, it looks pretty significantly stable, actually. And there's no real concern for a valve will fail early in life. What about the Evolute, the other one, the self-expanding? The 4-year data is out because that's a study that came out a little bit later. The 4-year data, it actually did show a p-value of 0.05. That TAVR remains a little bit better and the curves remain actually parallel and they haven't crossed over quite yet. So this is generated a lot of debates. Like, well, you have a study that's crossing over. Maybe Sapien is worse than the Evolute self-expanding valve. Unclear. Again, 4-year data, 5-year data. And if you actually look at the fine analysis of this thing, the surgical cohort at 5 year, let me go back. Surgical cohort had actually death and stroke. I did a separate table on this, but you add them up. Surgical cohort had a death and stroke. If you add it together, it's about it's still lower than the rather on this paper is 14%. On the partner 3 follow-up, it's about 10%. So then there's been debate as well, you have, better surgeons on the other trial, and you have worse surgeons on this side, and their outcomes are 14% badness at, 4-year follow-up, and the other study a lower rate on the surgical side, therefore tower loop worse on the other side. There's a lot of debate. Of course, every company is trying to spin it their own way. So it's really unclear. So we really need sort of long-term data that compares both valves, meaning randomized studies. Now, randomized studies, Edwards has more of the reality of life is that Edwards has 80% of the market. Medtronic has about 15-20% of the market. So Edwards is not going to do randomized studies. So Medtronic is trying to grow their program. So our valve is better. Use our valve. If we want to make more money, we want more market share. So they actually did this valve study, which is that SMART trial. They actually randomized Medtronic versus Edwards valve. And what they looked at is they picked a cohort of patients where they think their valve is going to look better. And what is that? Again, like we talked about, Evolut is a supraannular design. The valve leaflets are higher up, so you have a bigger opening where the valve is, as opposed to an intraannular valve where you're constricted by the annulus, so you're a smaller valve. So downstairs, patients that we would have put in 20 valves in, we have 2 cases today, we're putting Medtronic, we would have put in 20 valves in for SAPIEN, they're getting 26 valves downstairs from Medtronic because of this trial. So this is what, but then this is why that they did this trial to show that their valve may be better. So what is this? So basically they randomize 300 some patients to balloon expandable valve, that's SAPIEN, to self-expanding valve, that's the Evolut valve. They looked at hard endpoints and follow-up, and this is very in randomized study, so very well matched. So death, disabling, stroke, rehospitalization, basically the same. But then what they really sort of looked at is the biprosthetic valve dysfunction, and there's a couple of definitions for this, but balloon expandable valves had 40% failure versus 10% failure, 9% failure. So based on this, of course, like, oh my goodness, something is going on here. And this got published a couple of months ago. The secondary endpoints further is that you have lower gradients with self-expanding valve, which is again supraannular versus intraannular. So you have a bigger sort of opening is the argument. Again, effective orifice area is more with the self-expanding valve. And structural valve function, if you look at the hemodynamics, the self-expanding valve looks better. You have lower gradients. Again, supraannular design of the valve. So this generated a lot of heat.
So no rounded valve, right? Just native.
This is native, correct. And then if you look at the sort of more fine print of this thing is that structural valve degeneration, 32% on the balloon expandable Edwards, and then non-structural valve degeneration is basically small, severe patient prosthetic mismatch, or they have a lot of PVL, 18% on the balloon expandable side. So again, a lot of debate on this, but that's what they have. Now, the argument here that the discussion that Edwards people make, which there's a lot of them, is that what they will tell you is that they took a gradient, valve degeneration of mean gradient, anything more than 20. But that is not the VARC3 definition of valve failure. So they say, Edwards' side will say, oh, well, they came out their own definition, a random definition that they picked to make us look worse. Because if you look at the actual valve degeneration, this is the criteria. Moderate degeneration is 20 true with an increase of 10 over time. Or you have the severe degenerations gradient of 30 or more with the increase delta of 20 or more over time. So that they say, and that's not what was used in this SMART trial. So that's one of the criticism. And Edwards then came up with a lot of retrospective data that looked at smaller annuluses and annuli and then see what their outcomes are. And then what they're saying is that if we have, even if we have higher gradients, that doesn't really correlate with bad outcomes. So jury is kind of still out. I mean, it does a practice changing trial as exemplified by our behavior today. I guess we have 2 valves. They would have gotten Edwards probably a year or 2 ago. And now we have Medtronic. They're getting Medtronic valves downstairs because of this trial, which was published again just a couple of months ago. So, but there was in details, right? Every company is going to try to twist and form. And this is why this critical reading of literature is always important. You got to always read between the fine lines. Who are they randomizing? What is their patient population? What are the endpoints they're using? This is all designed and funded by the industry. So always keep an open mind. So where do we go from here? One, as of 2019, TAVR is being done more than SAVR for isolated SAVRs across the board in the United States. 120,000 TAVRs are being done per year in the US. In 2029, the thought is it's going to be 190,000 or so per cases in the United States. So the volumes are pretty high. So that the good news with that is that we should be getting a lot more data and long-term follow-up as well. What we don't truly know is how long is the valve good for? How do we further optimize procedures? Like I said, you put the valve lower, you're getting pacemaker, risk is higher. What does that mean long-term? Well, okay, we'll put the valve higher. Well, if you put the valve higher, then you may be putting the valve in front of the coronaries, then I cannot do a valve again in this patient. So then maybe I'm sort of delaying the surgical valve, and the patient is going to have to get surgery when they're 10 years older now. So that doesn't help the patient. So there's a lot of sort of these, how do we further optimize these valves? Questions remaining technically. You can always reduce complications. What do we do about bicuspid valves? Some of this is being answered, but what do you do about concomitant coronary disease? If there's aortic disease, aortic dilatation, what do we do? Some of these topics are topics of discussion actually tomorrow. If you can come tomorrow, we can discuss further more. And then the next step, next sort of thing to conquer is the aortic valve insufficiency. If you have severe aortic stenosis, no calcium, right? We use calcium to anchor these leaflets and valves in place. And so what if you don't have calcium and you have a leaky valve? How do we fix that? There's JenaValve that was a line AR study was published about 6 months ago and shows pretty promising outcomes that it's doable. And there's JValve and JenaValve. They were both bought out by this, Edwards. So they're going to eventually probably push them to the market. FDA approval they're expecting in the next year or so for AI. So this is also coming.
Are we going to be
Different
are we going to start getting the JenaValve?
Yes,
training?
as soon as it comes out. Yeah.
JenaValve campus is also just in Irvine, just like Edwards Life Science.
Yeah. Yeah. And Edwards is close by. Yeah. So that's what we have. So that is the end of it. Thank you. Questions from online or here? Let me go to this.
Dr. Aksoy, I have a quick question. Can you hear me?
Yes.
It isn't really about TAVR, but I always or not always, sometimes I get the question of balloon valvuloplasty as a bridge to surgery, but I haven't seen that done much in my very small career. Can you comment on that?
So that's a very good question. We actually did one yesterday. Patient was, and that was the first one, and probably I don't think we had done one as a bridge for the past, 5-6 years even. So if you look at the literature on the BAV in the United States, if you look at the cohort of patients who had BAV, the risk of mortality with BAV alone is about 6% across the board. Risk of TAVR is about 1%. So if we all feel like it's unfair to just do the BAV and leave the patients with a BAV and not a permanent solution, if you're going to do something to the patient, just might as well just put the valve in and get it over with. So that's what we usually do. We try to just put the valve in and give them a sort of more of a, permanent fix, so to speak, than a BAV, which is going to fail in a couple of months. And the other things with BAV is that you're, again, assuming the risk of sort of interrupting the valve, but you're pushing the valve out and it's going to recoil back. And you're not changing the leaflets. The other thing is you can create aortic insufficiency, and that aortic insufficiency can then trigger. And if you don't have a backup plan, that can make everything worse, actually. So when a high-risk patient comes in, we have done a lot of cases on ECMO and put the valve in and wean the ECMO afterwards. The one that we did yesterday is, again, one of those patients that we did a CT scan. There's annulus is 950, and 30% of the annulus is missing because of an aneurysm. So we didn't think that the TAVR valve will stick to it. So we had to sort of do this BAV option with the Impella and ECMO in place, actually. And we'll see how he does. But it's a good question. We don't typically do BAV anymore because it's riskier than TAVR, and it's just a bad deal. You were doing increasing the risk and not benefiting as much. It's just sort of lose on both fronts to a certain extent.
Got it. Thank you.
Coronary calcification sometimes is thought to get worse, and maybe aortic valve calcifications with statins. in these long-term studies, does it seem like statins actually increased the stenosis rate in these patients versus not on statins?
Right. So if you look at the coronary calcium, and Eric Yang will tell more about this, I'm sure. But if you look at it's actually interesting. So this comes up in clinics too. If you look at coronary calcium score studies and patient gets on statins, their coronary calcium score will go up actually in follow-up. Our escape in explaining to our patients like, well, calcified plaques don't rupture as much and it's more stable, and you're sort of putting a cover to stabilize that plaque more with the statins. But yes, the calcium does get more. So what that means for the aortic valve, I actually don't know. So does it increase calcium? Maybe. But I don't know that on the valve versus coronary disease. The thing of it is that actually the coronary disease process and the aortic valve calcium, aortic stenosis process seem to be very similar. But it actually, the treatments, the statins and things that like don't work for the aortic valve. So there's thought that it's not the same. There's other things in play.
If you're approaching aortic stenosis from an AS standpoint, statins don't work, but if you approach it from being a cardiologist and wanting to reduce events, they have studied that versus control groups, and you have a 20% decreased ischemic ASCVD risk reduction rate. So it's not going to help the AS, but you're going to have less MIs and other cardiac events.
And the other thing with the statin trials is that, you know, all these trials were done on patients with a valve area 1.3 grading or 25. Like, what does it mean if you have aortic sclerosis? This started like 10 years before. Leaflets are getting thicker. Let's put you on a statin. Nobody knows. I don't know if you can convince patients to take it either, actually. But I think that is a study worth doing, actually. Just put everybody on statins when they're 55. A little bit, I see a little bit of thickening on the leaflets.
Your coronary CTI, I would expect to see some coronary after.
Yeah, maybe we should screen patients with a little bit of calcium, a little bit of echo aortic sclerosis, and do it.
Yeah, you should get AV calcium scores then, because echoes are not going to be enough to look at detail to really distinguish what's sclerosis and what's not, so. But yeah, you have to convince them to get CT imaging, which is probably still very doable.
We're getting a lot of CT coronaries anyway, right?
Yeah,
For a lot of 50-year-olds now. And then LPA is a big risk factor. Everybody's checking LPA now. I mean, should we put people on this olpasiran stuff, like just knock out the LPA entirely, like 99% reduction in like LPA? Which one? Nobody we should.
It's funny.
So if you want a career out of this stuff, there's like Nobel Prizes sitting in this area, like seriously. I actually went to Amgen, like this is 6-7 years ago. I said, look, we should this reduces cholesterol a lot more than statins. There may be some inflammatory thing. There's this LPA, like maybe there's a little bit of an association. Repatha reduces 30% the LPA. Maybe there's going to be a valve thing. Maybe we should look at AS patients. Let's give them Repatha, see what happens. They said, no, it doesn't reduce inflammation. And so we are not really interested. So they didn't give us funding to do a study. So I wanted to look at 30, 40 patients, put them some aortic calcium, put them on Repatha, see what happens. But we don't have that. But I think it's a great study. It's something I'm dying to do. It's just, yeah, we got to sell it or get money somewhere.
It's
Funding.
tough because aortic calcium is not made the same way as vascular atherosclerosis, right? There's probably a lot of dynamics and high flow and other
Turbulent flow.
Turbulent
There's a
flow.
lot of other things.
Yeah, once
Again,
again, we have techniques for modifying coronary plaques. Is there anything used on aortic valve plaques?
So there's a couple of Twitter and whatever sorts of things that people do shock waves and go in and then soften the calcium, and then I don't know to what end. You're just causing stroke and breaking off calcium and then softening. Okay, what does it do? The valve is still kind of a mess. So I don't know what modifying the plaque for the leaflet is going to do for the patient. You can soften, maybe if it softens up, maybe the leaflet will be more mobile. And then maybe the gradient may come down, but leaflet is still a kind of messy shape. So I don't know that's the solution, but not a bad idea. It's just, it doesn't make sense to me.
Dr. Arson, this is Dave Madnick. I have a quick question about complications. Just, anecdotally, what is the time course that you will typically see things like stroke, conduction, high-grade AV block? Does that happen right after the procedure, or is there a kind of 1 week period? Patients get discharged and then come back with it.
Yeah, no, it's a very good and a complex question. So stroke-wise, 30% of the strokes, it turns out that patient had like maybe thrombus sitting there because they had undiagnosed AFib. It turns out there was a study several years ago. It turned out they put on like geopatches on people, and the people had 30% of the patients had like hidden AFib in the patients who had strokes. The other thing is that strokes that I've seen here is in the first day, typically. I had a couple of patients, like a few, I mean, like a week, I would say is like the most that I've seen, honestly. And like 5-6 days later, like, oh, I feel weird. I feel like numbness in my hand or something. And the thing of it is that, so it's in the first week up to, I've seen the majority will be in the first day. I mean, people wake up, we have people wake up, I mean, they're under anesthesia, they wake up like maybe an hour, they go to the PACU and they're like, oh, well, I have a little numbness in my legs or something, or 3-4 hours later I've seen, but majority in the first 24 hours. The stroke mechanism is thought to be several things, but we're like, calcium on the leaflets, we're just breaking them loose, that sort of thing. I mean, that is one piece. The other piece is you're sort of scraping the arch every time you're going through. So there's there's a filter devices are being placed so that the debris is captured in the filters. There's different sorts of filters in place. Sentinel device was approved several years ago. We occasionally use it, but the improvement in stroke rates are marginal, basically. Other filter devices that cover more of a territory in the arch are being trialed as we speak, actually. But generally, strokes are earlier in the course. The pacemaker thing is interesting. The also same thing. You see it sooner than later. Actually, in the first 24 hours, if you're going to need a pacer, it becomes more obvious. We actually did an EP study in like a couple of these patients as we were ballooning, and we saw that his HV interval, his all that sort of conduction system with the EP catheters, they get delayed. Every time you balloon the valve, it gets longer. You inflate the valve, it gets longer. And over time, it gets worse. And then it recovers itself in the minutes, actually, is what we saw on the EP studies that we did simultaneous to the TAVRs. So generally, the pacemaker risk, we keep the pacer in overnight if we're worried about the block issue. And by the next day, usually it recovers. And if it doesn't recover by the next day, we say, okay, well, we'll go for the pacer. And if you follow those patients up, it turns out that even after the pacer, they don't really use the pacer after several months out. But sometimes it takes several days to recover. But we usually decide on the pacer in the first day or two. I will say we had, we had like one or two out of like, we're close to 2,000 now. I mean, all of these, I heard of 2 patients dying in the first like 2-3 weeks of this procedure, and we never found out why. Why these patients died. The only thing I can think of is maybe they went home and died because they went in heart block, like a week after, 2 weeks after. It's impossible to know. And one of them had an autopsy. They didn't see anything. Valve was fine, heart was fine. And how are we going to diagnose heart block? On autopsy is beyond me. But those sorts of things. But usually the strokes and the pacemaker, heart block stuff happens in the first day or so.
Who do you send home as side?
Thank you.
Patients who have right bundles, bifascicular blocks. Our pacer rates, if you look across the board, 9-10% are the pacer rates. In the US, we were at some point 0.8%, 0.7, 0.8%, very low. We were putting the valve high. Now I'm putting the valve a little lower, so then we're getting more pacers in. I think there's also occasionally you get more like a run of right bundles and bifascicular, trifascicular blocks at baseline. We tell the patient 30% chance you'll need a pacer. Some of them go home fine and they haven't had issues, but I mean, our pacer rates on average are 3-4% on the whole, if you look across the board. But so the people that we sent home with zero patches are, bifascicular, right bundles, trifascicular blocks. Low threshold, if they say, I'm dizzy, I don't feel right, anything skipping beats something, we never send people. So we stopped the beta blockers, the calcium channel blockers, like 48 hours in advance. And we don't start it for about a week or two, unless we are like, oh my goodness, they have AFib, heart rate is 120, we got to put them on something. Unless that's the case, we don't put people on beta blockers for about a month, actually. back on those medicines. And then eventually you see the EKG, everything's okay, then you go back on beta blockers. So little things that we do to try to optimize as much as we can, but you're traumatizing, you're punching the conduction system.
Do you send them with the real-time Zios or the ones that are delayed?
We didn't have real time now. We used to do that. We didn't have the real time until like year and a half ago, actually. They just put that on the Care Connect Epic thing like 2 years ago, maybe, right? Something like that.
Yeah.
Yeah, now we're doing real time, but before then it was the other way, the old system. Okay. So everybody come tomorrow, free food. Also free food now on the 6th floor. So if you're in the hospital, come by. Okay. All right. Thank you, everyone, and have a good weekend.
You want my rice?